Hello everyone, this is Chadi Alraies from NCVH from New Orleans in 2025. I'm really privileged to be with Dr. Costantino Del Giudice to talk about subintimal management and also recrossing for patients with peripheral artery disease. Costantino, thanks for being with us.
Thank you.
So recrossing or subintimal reentry is a new technique for CTO. Can you walk us through the algorithm and when to use this technique?
Yeah, the problem in subintimal recanalization is that in the most part of cases we have a risk of failure of the procedure. More or less 20% of the cases we didn't arrive to perform a subintimal recanalization of the femoral superficial artery, and so we need to perform a more complicated procedure with a distal approach. And in these cases, it should be interesting to have some reentry devices, but they have limited, they are expensive and they increase, they complicate the procedure. Thanks to the Apani company, we developed a subintimal reentry balloon. It is a double lumen balloon that allows to perform a subintimal reentry, just performing, creating a fenestration in the antegrade part of the lesion in order to pass a second guide wire in the opening that we created in the intima.
Yeah, so let's walk through it one more time. So you have a device, you park it in subintimal space, right?
Yeah.
It has double balloon, and then one balloon will inflate.
Yeah, it creates just an opening in the tear in the intimal space, and allow the passage of a second guide wire that is in the second lumen.
Yeah, and this device will be presented at this conference, correct?
Yeah.
So
we already performed one study that was published 3 years ago, and now we presented the 3 years follow-up. The interesting thing is that at the beginning we observed just an improvement in terms of the length of the procedure, exposure, X-ray exposure, and technical success of the procedure. But now, at 3 years, we observe that there is a reduction of amputation and reduction of the mortality, because probably what we think is that the quality of the subintimal recanalization that we create is better, because this balloon allows to direct the reentry where we want, and also the quality of the reentry is less angulated, and this way the results are patent more long term.
Yeah. So when you say decrease in amputation, compared to what?
Compared with the conventional subintimal approach, because the study was a retrospective study with a matched group with the same characteristics that were treated without the balloon.
So whether the operator was left with any discretion, whatever device they want to use to re-enter, it wasn't a specific device to use.
No, it was really a retrospective study. We performed
propensity matched analysis.
Yeah,
you matched the cohort. Okay, got it.
That's it.
And so 3 years, amputation is less, duration of the procedure is less, radiation is less, and success is good. And in terms of wire, when you say you are opening and going to the back to the lumen, is it 014, 018? What kind of size of wire?
It's a 14. 14.
014, okay.
Yeah.
And then the treatment of this, when you go re-entry in this study, did the operator opt for stenting or just ballooning?
Not obligatory. It depends on the lesion. It depends on the presence of calcification. If we can perform a ballooning, just a drug-eluting balloon, for example.
Interesting.
And if the result is good, lift like this. Or if the result is not good, as usual, we put a stent.
Perfect. Yeah. Well, thank you so much for sharing this result, and also for joining us at NCVH TV. This is Chadi Alraies coming to you from New Orleans and NCVH 2025. Costantino, thank you so much.
Thank you.